Mr. Chair. And as you mentioned, I am the Executive Director of OK-SAFE, and that stands for Oklahomans for Sovereignty and Free Enterprise, and we're the token grassroots group that's been allowed to speak at these committee meetings, and we appreciate the opportunity. Thank you. The presentation is on healthcare reform, IT security, and privacy issues and concerns. I always like to start my presentations by laying the groundwork of where we're supposed to be and who we're supposed to be serving. In the beginning, God created the heavens and the earth and all things that were on it. He created man, and he gave man dominion over all those things. What he did not allow was to have man having dominion over man. The Declaration of Independence, which was a seminal document, a declaration, recognized the fact that people have unalienable rights that are given to us by our Creator, and that governments are created by the consent of the governed, and they are to protect life, liberty, and property. The Bill of Rights acknowledges this in the 4th and 5th Amendment, which our legislators took an oath to uphold. And that says that no person shall be deprived of life, liberty, or property without due process of law, nor shall private property be taken for public use without just compensation. I would ask you to remember that. The Oklahoma Constitution cites that also in Article 2 in Sections 1, 2, and 7, and it says in number 7, no person shall be deprived of life, liberty, or property without due process of law. And again, I would ask you to remember that as we proceed. 6 parts. I will try to hurry to get through and respect the time. We've had several presenters, and one today, admit or acknowledge that there's a creation of a federal data hub taking place at the federal government. This is a graphic of it that was issued by the Director of National Intelligence in 2008 from a publication called Vision 2015, a globally integrated and networked intelligence enterprise. Why is this significant to the exchanges? Because it's a data hub, and this system, this beautiful graphic, it's hard to picture when you're talking IT and connections, but the graphic here explains it, what this is, and it allows for the seamless flow of information without regard to jurisdiction. And it requires the elimination of institutional and jurisdictional barriers for information sharing. And the packet that you have has the PowerPoint in it, and I would ask you to circle the 3rd bullet point. There's a PowerPoint in your packets. And there it says, state laws, regulations, and policies that inadvertently and unnecessarily prohibit or significantly limit the exchange of electronic information have to be changed to accommodate the seamless flow of information, and that includes including health records. There's the document that it came from, and now this is the Federal Data Hub, the new American Idol. And it is not because it can sing, it is because it is being sacrificed to, and its goal to be in place is by 2015. A little bit of history of how we got here. I won't take a lot of time with this. During the early 90s, in the 80s, the internet was a closed system between researchers and universities and between divisions of the Department of Defense. Al Gore introduced a law, and it was passed, and it was the High Performance Computing Act of 1991. And this moved the internet, as it was called a network, to the public. It made it available to the public. So it went out of a controlled environment out into the public. In 1993, they issued another report under Clinton and Gore that says Technology for America's Economic Growth. That year is significant because that's also the year we adopted NAFTA as a trade policy. This time frame in our history was when everything was being reinvented. There was reinvention of the corporation, reinvention of government, reinvention of education and healthcare. And the reinvention solution all was dependent on technology. It had to move to an input-output strategic outcome technology process. Today we have ubiquitous or pervasive computing. When we moved to that, there was a paradigm shift. We moved from government to not business process model. That required the digitization of everything so it could be quantified. That means digital persons, places, things, and events. And events are activities. Data on persons, places, things, and events is being collected, aggregated, analyzed, and shared across jurisdictions, both regionally and nationally, and now internationally. And technology has advanced to the stage now where It has the ability to locate, identify, and track, which is also surveillance, persons, places, and things remotely. You'll never know that it's taking place. The IT components of two significant pieces of legislation was the Real Health Care Reform Law was the stimulus bill, and I heard that at a provider summit in June in Tulsa. And that stimulus bill contained a law within a law, and that was the High-Tech Act. It's noted there in your paperwork. It's Public Law 111-5. And in there was the adoption of electronic health record technologies, the whole technology spectrum, and requirements for their meaningful use. All right? You can't just have, yeah, I'm going to buy technology. You have to have measurements to make sure people are actually using them. That's where we saw more funding for the state health information exchanges and cooperative agreements, which are a contract between a state-designated entity and the federal government to adopt those changes. The Affordable Care Act was actually two laws, the first one and then its amendment called the Affordable Care Act together. The IT provisions are here in the Affordable Care Act and those provisions. And when you look at that, you would actually just consider that in your mind. Those are IT contracts for every provision. Every section, whether it's quality of care, programs, reimbursement structure, which is the health insurance exchange, operating rules and standards, and health IT workforce. The tech schools and the community colleges are supposed to be producing workers to work in this industry now. If you took out IT and funding for it in both of those bills, you would gut the bills. All right, healthcare reform. Now, with that background, we can actually define what healthcare reform is. And healthcare reform is really about the health IT, developing the nationwide health information network that will enable that seamless flow of information across boundaries, regardless of jurisdictions, and allows for a growing global surveillance system to function. You can't have it unless you got the money and the IT technology in place. It is predicated upon everybody adopting and having an electronic health record on every single person. That health record is to follow you from cradle to grave and is not to be confused with a medical record. A health record includes information about your lifestyle choices, counseling, conversations you have with doctors, and other vital events. They're universal and are being shared globally. It requires standardization and interoperability, and I'll explain what those are. And electronic health records include our genetic information. And that's being used for research purposes without the knowledge or consent of the individual from whom the information was extracted. It's rights killing in its essence. When I said it was cradle to grave, it literally is cradle to grave. We've moved to electronic birth certificates and electronic death certificates. And Representative Cox, who is not here, passed the electronic death certificate law last year. These are interoperable systems recognized across boundaries, and they are standardized from state to state. So if you're born in one state and die in another, the electronic health record can follow you across jurisdictions. Vital events includes activities that you're engaged in between birth and death. And when you are discharged from the hospital, a GIS coordinate is attached to your record so they can track medical incidents down to the block. It's permanently linked to your electronic health record, and it is NEAM compliant, which I will get into in just a moment what that is. This is a graphic I drew to try to explain what healthcare now is. When you go to the doctor, all the information flows from the patient to the right, and that's your provider or your healthcare network, which is going to these exchanges. That is shared with the government and with research universities, and each of those entities have information sharing agreements onward right off to pharmaceutical companies like Novartis, who bought an entire block right next door to MIT after Massachusetts adopted Romneycare, so that they have access to data that they would not have normally have had access to. So now when you go to the doctor, there's a whole lot of other people in the room with you, and one former legislator characterized this now severs the relationship between a patient and a doctor, because now we're inserting IT and all these other contractors are in the room with you. Standards are what makes it work. The laws that you pass say that we're going to meet nationally recognized standards at the federal level. Well, the standards are the common set of rules, guidelines, coding, etc., that makes it the same from state to state to state, regardless of where you are. This establishes uniformity. HL7 Health Level 7 International has been adopted by the United States. It's a global standard for healthcare reporting. Coding is ICD-10, which is International Classification of Diseases version 10. As the name implies, it is a global coding system. And I think if you go to the doctor, if you have a cold, it's called rhinitis, that's a particular cold. If you say, I have suicidal thoughts, that's a code. If you have any kind of a discussion, sexually transmitted diseases, a photograph of whatever it is that you're going to the doctor for becomes part of your electronic record, and it's attached to it's coded. That's international. Interoperability simply means one system can communicate with another system, and the standards allow that to happen regardless of software here and software here or hardware. It can now communicate. The state's chief information officers, the Oklahoma Healthcare Authority, the trust that was created, the regional health information organizations, which are networks, all have adopted common standards and interoperability requirements, and the U.S. and the state's healthcare systems must comply. All federal grants that involve IT, whether they are for healthcare, law enforcement, or education, require compliance with federal IT standards and interoperability capabilities, and all federal standards are international standards and globally interoperable. So that you can rethink Race to the Top and core curriculum standards because it's exactly the same and it is involved in this. National standards. Representative Gross said this is an acronym-rich environment, and it is. Inside your packet, I've included a glossary of different terms, and it's 2 pages, and that's only a partial list. It's a way to obfuscate what's actually happening because you start talking in these little acronyms, and until you take the time to define them and go find what agency is implementing that acronym and what the funding is, then you have a hard time actually understanding what's happening. I'll give you 3. The Federal Health Information Model is the information model that the whole federal government at all levels and branches is adopting. And what that means is that this is the type of information that you have to acquire. In this context, it has to do with medical information. It is part of the nationwide health information network, which can be described in layman's terms as a network of networks. What is a network? Would be maybe 10 institutions have agreed to share data. You have a hospital and a clinic and a lab and the pharmacy with e-prescribing, and then you have the research university that's tied in, and you have maybe the payer, the insurance provider. That's a network, and they're going to share login access to that network. That's a network. Here's another network surrounded a regional health information organization, and those networks can communicate. That's the nationwide health information network. It's part of the national network, and the little box is breaking this up, overlaying some of the graphic here, but NEAM is the National Information Exchange Model. NEAM is the data requirement that makes this thing work, and it was originally devised and called the Global Justice XML language, which means it's global justice system developed for the Department of Justice and the Department of Homeland Security when we developed the fusion centers, again for the seamless flow of information across jurisdictions. It's now just been renamed, called NEAM, and Health and Human Services has been brought into the fold. This is a graphic that I picked up from neam.gov, and if you look at it, the NEAM core is what enables all of those components of government, all levels and branches, in order to communicate with each other seamlessly. If you'll notice, the branch that's a little pie or petal is Human Services. That's where our Health and Human Services is. That's where your exchanges are. And that is broken out on the pie chart on the right to show it revolves around a common core of interoperability. All of those parts are what make it work in order to flow, the information to flow seamlessly. This is it blown up, and again, remember, it's about tracking persons, places, things, and events. This is what enables that to take place, and you can study all the different branches and levels of government that are involved in this. Identity. In order to access these networks, first you have to be identified as whether you're a carbon-based life form or a silicon-based life form, because to a computer, you're just an it. So there are different requirements if you're carbon-based versus if you're silicon-based. Why? Because a computer can ask for access to a network just like a person would who's logging in. This is called the Federated Identity Management, or FIM, that allows you to log in once. And I have the specifics on where they use carbon-based life form or silicon. Again, because it's a computer system and you're nothing more than data. The two exchanges. This state established the Health Information Exchange through a series of laws, and Health Information Exchange through a series of activities and laws that parallel what the federal government has been asking. So when we're talking about exchanges, you have to remember that it's a verb and a noun. A verb means that it's actually the process of sharing information across a network, and an entity. The Health Information Exchange exists now in Oklahoma, and that's the progression of legislation and activities the state's been engaged in to develop it. And it really kind of speeded up in 2008. We passed the Senate Bill 1420 to create the Health Information Exchange, Oklahoma Health Information Exchange. 757 was this Health Information Infrastructure Advisory Board, and John Calabro was the head of that to get it to do an assessment. And the big kahuna was the Senate Bill 1373, which established the trust, which we'll get to in a minute. The Health Benefit Exchange is a plug and play. Whether it's state-based or federal, it plugs into this network. Some of you who are old enough to remember component stereo systems. You could buy your speaker, you'd have a receiver, you'd have the turntable and the tape deck, right? All those components, you could buy them from different places, but they plug in and produce sound. That's what this is. It's plug and play with components that work together. The Health Benefit Exchange will be and is tied to the IRS to determine eligibility on your taxes. That means the federal government would have access to the Oklahoma Tax Commission. There has to be a connection there. Social Security Administration to verify citizenship, and the Department of Homeland Security to verify immigration status. And then again, now you can probably understand why it was so important to get E-Verify. Both systems are going to be linked together and they're NEAM compliant. NEAM allows for data collection, aggregation, analysis, and sharing, and will require a federated identity to access it. Global adoption. This is not an Oklahoma or a U.S. initiative. This is a global initiative. And in 2005, the World Health Organization issued a report that says, man, in order to have total information awareness to address emerging threats, everybody needs access to technology. Everybody has to have an electronic health record. And I can just tell by looking at that guy, he's saying, man, I wish I had an iPhone. All right, global adoption. There's two very influential organizations that are promoting that. One is the Health Information Management Systems Society, which our next speaker is a member of. And what it said in 2008 was the U.S. is the only country, for example, that has not adopted a universal health care system. And the first step in developing that is establishing an electronic health record on everybody. Capgemini was a contributor to this report, and our state has hired Capgemini, paid them $1 million to do the state's IT assessment. The Global Health Data Charter was issued by the World Economic Forum, and again, it's about electronic health records and interoperable systems for everybody. The U.S. is a signatory to this charter, and the charter states there will be secondary usages of the data that's collected. This is a use case example, and we have, when I said it would be shared globally, they did a test in February in Florida, and it was hosted by that HIMSS organization, and the Office of the National Coordinator was there as a participant. And they did a demonstration of sending a medical record from a U.S. physician to a physician in Europe, and he sent it back. So we can say the government is bidirectional now, with the sharing of information. So it demonstrated that it's bidirectional and global, but also the purpose was to demonstrate that the nationwide health information model network is global. And it's kind of running off the screen here. When it's sent to the European physician, with whom does he share it? Nobody here would ever know. And our laws don't apply over there. The Office of the National Coordinator was created by executive order by George Bush in 2004 with the stated purpose of making sure everybody had an electronic health record by 2014, and we're approaching that date. They were, in order to produce their reports, by law, 2 committees were created, a policy committee and a standards committee. And those 2 committees had stakeholders that participated. Guess who the stakeholders were? The IT companies, the chief information officers, the research universities, and the insurance companies. So they're at the front end. They devise the policy. The Office of the National Coordinator adopts the policy, sends it to Sebelius, and Bob's your uncle, we got the product, right? This is just an example, and it's not to accuse anybody of anything, but CURAM was one of those stakeholders that participated, and CURAM has now on enrollment and eligibility. So now CURAM is registered and hired a lobbyist in the state of Oklahoma, and those lobbyists have already started visiting legislators saying, we're here to get your contract. This ONC has issued 2 strategic reports, and I'll just bottom line it here. Both will leverage the national, the NEAM model. And change, yes we can. And what do you have to change? Any laws about disclosure and privacy that were written before there was interoperable health IT and widespread exchange of health information, federal and state laws that inadvertently and unnecessarily prohibit or limit the appropriate exchange of information have to be changed, must be changed. And the government gets to decide what's appropriate. Technology nullifies principle, and it's not showing up very well on the screen. This country used to be based on principle, and our laws reflected that. Now, the laws are reflecting the whims and desires of one industry. Government, industry, and academia, is also called public-private partnerships, are now called strategic alliances. This is an example from 2009 when OU partnered with IBM on a pilot project in Tulsa, and they shared information between 355 physicians. So it was a demonstration project of sending records between hospitals, physicians' offices, local ambulances, fire departments, and patients. And that was 2009, and I think they're a lot more sophisticated by now. That's an example of this triangle, this strategic alliance, which is an anchor company, typically a multinational corporation that partners with academia and the government supports it. And how the government supports it is by changing the regulatory environment, policies and permitting, and tax incentives to the private sector entity and academia. Now, if you look at this triangle, who's funding all 3 sides? We are. That's called your knowledge-based economy, is based on this model. And this is not free market. This is also sometimes referred to as a Swedish triple helix, and there's research papers on it all over. One fused system. When I started looking at healthcare reform, I'm not an expert on Medicare or Medicaid. This is not my area. But I recognized the fact that what was happening in healthcare was exactly the same thing that caused us to create the fusion centers. The fusion centers' premise was, man, we got to move away from need to know to responsibility to share, and we have to remove all barriers to information sharing regardless of jurisdiction. That's exactly what's happening in healthcare. Both systems are NEAM compliant again. The prior speaker and others have referred to some efforts by the federal government to engage in information sharing. They have to work out all the kinks, and so there's this Connect project that's going on, and all these non-traditional partners are sharing information with each other. In particular, they're sharing their medical data back and forth from all their employees and to get all the kinks out. And you can see who's involved there, and here's the list. It's 31 different agencies that are actively involved in this, including NASA, Department of Labor, Department of Justice, HUD, Department of Energy, Department of Homeland Security. The fusion centers had their guidelines published in 2005. They've added an addendum or an appendix in 2011, and so now the medical records, because of public population health, is a hazard that needs to be addressed. Their medical records will be shared with the fusion centers. The government is building this apparatus. State initiatives, I've kind of hinted at these. Since 2004, these are the activities, just as some of them, that the state's been engaged in to comply and build help the Federal Data Hub come into existence. And again, I'm going to mention some of the laws that helped it. In 2009, we established, the Speaker of the House established the Government Modernization Committee, and we created the position called the Chief Information Officer. I would just caution you, you have to watch every single thing Jason Murphy does. He's a nice guy. He also created in there the Health Information Advisory Board. That's the law that defined electronic medical records and health data exchange. In 2010, we hired Capgemini, and they're talking in their report to go into a virtual server. And Senate Bill 1373 created a trust, which is going to be the subject of the next few slides. And the federal government, the fusion centers went federal in 2011, which is always their intent. In 2011 is when we started having to address the health benefit exchange, the early innovator grant, which had all the IT requirements in it. Your chief information officers are significant to this process because they require they get to oversee all the purchases of IT, and everything has to be to the federal standards and interoperable. The trust. This was created by law, Senate Bill 1373, and I'm not casting any aspersions on who wrote it. I'm just pointing out a fact. They've issued 2 reports to the federal government, and one is called their strategic report, and the other one is their operational plan. They have 7 trustees. One of the trustees is our next speaker. In their reports, they have said that they will comply with the Office of the National Coordinator's IT standards, and the health benefit exchange will be plug and play. Plug and play is layman's terms. They're putting it in computer lingo, but that's what it is.
Amanda, can I interrupt you just for a quick minute?
Yeah.
Could I ask you through the rest of the presentation to please refrain from personal mention or attacks?
I will. When we had meetings, you have certain entities or instruments that can make it easier for certain companies to get contracts. So, this is a definition of a trust. There's all kinds of trusts that can be created. This is one definition of a trust, is a combination of firms or corporations for the purpose of reducing competition and controlling prices throughout a business or an industry. That's one definition of a trust. This trust, the trust indenture is in your packet, and some key provisions of it are noted on there, and I would suggest that you read them. And I question the wisdom of the legislature creating such a powerful entity that has virtually no oversight. Archimedes, this is kind of where we're heading. IBM has the same kind of thing. It's a virtual doctor. This is going to help fill the void when we don't have MDs in the rural communities or anywhere. This is going to fill the void. And it will make decisions based on quality-adjusted life years and give you the costs for quality-adjusted life years. And this is a software program to diagnose and treat carbon-based life forms. Inside your packet is also a wire diagram from the trust. And this wire diagram, if you're not familiar with reading these, just follow the arrows, and that's the direction the information flows. And it is my belief that the payers would be the health benefit exchange, and that's a plug and play, and it fits into this grid work which is being developed in the state. That's the other picture. This is the health benefits exchange logic model, and in order to access this, everybody's going to have an ID, and it does connect to your bank. Privacy. The government assures us that they have privacy and security laws that are intended to protect us. I added the bars. While all these things are happening at the state level, the Department of Homeland Security issued a notice of proposed rulemaking that wants to dismantle the Privacy Act of 1974. And again, that would show up better if you had our systems are not compatible here. And the Privacy Act basically protected information from being extracted from a person, and at the federal agency, the person who's actually accessing the information would have to disclose that. The Department of Homeland Security now wants to shut off those disclosure requirements to build this. What does DHS want? And again, that list is in your packet. It is they want not only your full name, date of birth, social security number, citizenship, physical markings, tattoos, etc. They want your medical records. That's in there's a comments that EPIC, privacy organization, issued back to the Department of Homeland Security when the notice of proposed rulemaking was open for comments. This isn't all. They want this information too, which I won't read. They want all of this information too, and that, without having to disclose it to anybody that they've got it. So now the question is, who does DHS report to? Human rights. There's going to be human subjects research because of the information that's being extracted. The Food and Drug Administration plans to make sweeping changes to federal regulations on human subjects research. This flyer is also in your packet. This is a report issued by the Citizens Council for Health Freedom, and they want to be able to have access to private patient data and biospecimens without patient consent. Human subjects research without consent and without oversight either. Security. In the public's mind, when you think security, you think in one thing, but actually what it means is we don't have any. When you had more security when there were paper records, and now we're going to electronic records, which is really vulnerable to accidents because it gets shared with contractors and sent out. This is an example of a security breach where 20,000 emergency room patients' names and diagnosis were put online, and they were online for a year before somebody noticed it. How'd they get online? Because they were sent to a university and were being used as a homework assignment for a student in bio or life sciences. Experts in medical security said the Stanford breach spotlighted the persistent vulnerability posed by legions of outside contractors that gain access to private data. There's a lot of money in that trumps privacy rights and security. There's an example of some of the contracts that have been awarded. Accenture Health predicts that the market for electronic medical records and electronic health records is going to be $19.7 billion in 2013. And there's a lot of money in funding. The Oklahoma Healthcare Authority awarded a $281 million contract to Hewlett-Packard's Enterprise Systems. And in their contract, which I read on page 58, E58 and E57, it says the two exchanges are going to be connected. And they're fulfilling the National Health Information Network. Conclusions. Believe it or not, the American people are not your slaves. We are not simply carbon-based life forms. Government, via healthcare reform and other federal initiatives, is establishing a globally networked and integrated intelligence enterprise, one that includes an extraordinary amount of extremely personal, detailed information about the American people. Government, in its attempt to be an all-knowing technocratic God and to satisfy the IT industry's insatiable and ever-changing appetite, is doing an end run about human dignity and nullifying our God-given rights to life, liberty, and property. And there's a book that I recommend to everybody on the panel, and it's called Biblical Law, and encourage you to remember your first love. And in there it states, nature has not made men slaves, but free, with an intrinsic right to life, right to liberty when they infringe not the equal freedom of others. Not only so, but liberty is a divine principle. Recommendations is repent, and that means do a 180 as the legislature to turn back. Do not establish a state-based exchange. The idea is that you can do something different than what the federal government's requirements are. The flexibility you have is only in the differences that really don't make a difference. Allow people to escape this system who do not want to participate, and that includes providers. Don't penalize any provider who doesn't want to participate. Repeal any state laws that prohibit individuals from seeking alternative health services. And I'm not talking legalized pot. I'm talking homeopathic medicines. And last session or 2 sessions, laws have actually started tightening it, making it harder for people to seek alternative health. Terminate, and this is no offense to anybody meant here, but you're going to have to terminate the trust. Audit the Oklahoma Healthcare Authority. And as OCPA pointed out, their expenses far outweigh their benefits. And this is a radical idea, is maybe ought to adhere to the Oklahoma Constitution and work to restore liberty. Those are the sources. And if you're not too mad at me, I'll take questions.
You know, my understanding of the use of technology, let me back up. Anything can be used for good or for evil, whether we're talking about technology or they're talking about a handgun. So there's no doubt there's opportunity for the use of evil, if you will. Short of not using technology at all and taking healthcare, if you will, back to, I don't know what, pick a date, 1890 or something, how do we improve efficiency, improve outcomes, reduce duplication, those sort of things, which I believe is the genesis of a lot of the information you've presented?
The recommendations that I would make is that there's a lot of restoration that needs to be done, and technology is not the solution to everything. And I say that with a piece of titanium in my ear so I can hear. And so I recognize that there's some benefits. But when we start changing laws to accommodate advances in a very fickle industry, instead of basing our laws on principle, unchanging principle, we're now moving to the very dangerous position of IT gets to decide what our laws are and what's appropriate just because they can do something. There are people in the research world that do not think like normal people, and they would take a human embryo and maybe pair it up with a fish, and they're actually doing this. Now, that's not the kind of thing you need to make legal just because they can do it. I would suggest that we go back to try to restore, like I said, don't make anybody participate in the system who doesn't want to participate. If I go to the doctor, that's a trust relationship. There's not too many people you get undressed for. And what you say to a doctor and what you actually discuss and what your concerns are should stay between you and the doctor. Now, he can have a computer system within his office so he can be more efficient with his own records. But this information sharing, this leakage to everywhere, and I know a lot of what's happened has been done out of not knowing what it's actually attached to. So I'm not condemning anybody. What I'm saying is that you have to know what you're dealing with, and is that the federal government is not supposed to be running health care.
Okay, Amanda, with that we will end. Thank you for your presentation. Oh, I'm sorry, yes.
All right, thank you. Thank you, Amanda, for coming and presenting today. I do have a question for you on, well, I can ask on all these, but we don't have time to allow, but I do wonder on repealing state laws prohibit individuals, item number 4, from seeking alternative health care services.
There was a law that was passed in 2010, I believe, that was making people who offered like chiropractors and other kinds of services had to be qualified or certified by the state. And that, again, is inserting the state in between somebody in a business transaction. And I think that that's the kind of thing where government doesn't have to regulate every single thing. If that chiropractor or whoever it is really bad, word will get out and people won't go. It's those kinds of things. Like, this is a very big subject as far as where people can choose alternative health treatments. And what I'm asking is make them all legal, not pot. I'm not talking about that. But there are other alternatives. There's natural remedies that people seek, and what you've been doing with legislation, whether you're aware of it or not, is closing the door to those alternatives. Those alternatives must be legal in order for people to exercise their liberty. And it doesn't mean that they're lawbreakers. They don't want to participate in the system where our medical records and our information get shared with the government for national security reasons.
Thank you. Number 3, I'm going to start with the second half. Do not penalize providers who opt not to adopt EHRs or participate in the system. From your understanding, is the state actually providing any type of penalty, or is that the federal government that would penalize doctors and hospitals by not having adequate compensation toward Medicaid if they don't participate, if the hospital does not participate? I mean, can you give me an example of is the state actually penalizing?
There's ways to penalize, like cut off funding to somebody or cut down their access to a lab or a clinic or e-prescribing. That's how you can penalize somebody, but just shut them out of the system. That's what I mean. The people who do not want to participate should have all the rights that those that are in the exchange. The rights should be the same for those who are not in the exchange to seek treatment, clinical, access to the labs, and don't make your pharmacies all go to e-prescribing. I mean, paper prescriptions. That's the other component of this, everything, because everything becomes part of your medical record, your health record.
Thank you.
Thank you, Mr. Chairman. Thank you, Amanda, for your presentation. A lot of the information is very frightening. And I think a lot of us, from the very first mention of a federal data hub or cloud or whatever it is, have had some serious concerns. I'm trying to find it in the presentation, and I can't at this point. You had made some sort of statement about state privacy laws or some existing laws that existed that would have to be nullified or changed in order to comply, or that would automatically be nullified. I didn't quite catch that.
The wording in the Office of the National Coordinator's document says that since privacy and disclosure laws were written before there was interoperable IT, interoperable information technology, and the widespread use of health information exchange, which, is kind of like what caused what. Any laws that inadvertently, I think it's on the very first slide that has the big graph on it, this is the third bullet point. Their quote is, any laws that inadvertently and unnecessarily prohibit the exchange of information, including health information, must be changed. And I can tell you by looking at some of the laws we've passed in this state, we are complying with that. So as those laws that inhibit a flow of some data, you're being brought a mandatory language to amend a law to allow it. And I wish Representative Cox was here because I think he ran a couple of them. And it had to do, and I think it's because he's a doctor, he gets asked to run some bills that allow the free flow of information. I have the number someplace, but it's that kind of thing. So it would ask you to be on the alert for things that are changing the laws about information flow. And it's to create a more comprehensive electronic health record on everybody. And comprehensive means comprehensive. Everything about you. If you go to a counselor, marriage counseling, suicide counseling, anything, that's part of your electronic health record. And that does not stay put. It's no longer private.
Thank you.